Thank you very much, Jerry. Thank you very much, Jane. It's a genuine pleasure to be here. Good. Yeah, so I'm going to be talking about the Summit D study. And Summit D stands for something along the lines of supporting medication adherence through messaging and IT for diabetes, something along those lines. So this is a project that has recently been funded by the NIHR programme grants people in the UK. So this is the research arm of the NHS. So as the title suggests, it's about medication adherence, it's about text messaging, and it's about people with type 2 diabetes. The thing which I think is interesting about this project in particular is one, that it's kind of aiming to do a population-based intervention, an intervention with genuine reach. And then the other thing which I think is interesting is that we are really trying to make sure that this is a thing that could be implemented in the NHS in the UK in a sort of time frame of sort of 6 to 8 years. And that's those two things, the reach and the implementation, are things that we're going to keep an eye on all the way through the talk. The person there is Professor Andrew Farmer from Oxford University. He's the PI on the project, particularly focusing on the trials aspect. But a lot of the work is being done in Manchester, and a lot of work to set this up has been done in Manchester, which I'll tell you about, particularly around the development of the intervention. So what should one put into these text messages? So that's what I'm going to be talking about today. Okay, so as you can see, over 3 million people diagnosed with type 2 diabetes in the UK, a smaller number in Ireland, but still a considerable number of people. Given that this intervention is focusing on medication adherence, I think it's notable that there are over 800,000 people in the UK taking medication for their diabetes at the moment, and that number's only going to go up. Medication adherence is a general problem. Adherence is a problem generally with medication. With regard to diabetes specifically, it's been estimated that about a third of people stop taking their medication within a year of being prescribed it, and that in the longer term, about 70% of people actually take their medication as prescribed. So on the one hand, we've got a lot of people supposed to be taking this medication, and then on the other hand, we've got a lot of people who are not taking the medication optimally to get the benefits in terms of reducing complications. So lots of people, a big behavioural challenge. So what do we know about medication adherence? I think we know a lot about how not to increase medication adherence. This is a Cochrane review, which I think was published 2 years ago now. The author's conclusions, I think, are quite sobering. There's been an awful lot of studies that have tried to change people's medication adherence, but the authors concluded something along the lines of the interventions are very complicated and they don't seem to work. So that's a kind of not a good combination. That I think we want something which is simple and which would work. They also say that we need to start thinking about alternative approaches which could be more feasibly implemented on a bigger scale. Because if one has an intervention which, say for the sake of argument, involves a healthcare professional having some sort of conversation with a patient, that's going to be phenomenally expensive to scale it up to 850,000 people in the UK. So we need to have an alternative approach. So I imagine what's coming next is not going to be a big surprise. So would you believe text messaging may be a sort of solution, given that it could be, in principle, very cheap per person to do this sort of intervention. So this was taken. This picture was taken from the BBC website a couple of years ago. And this was with coronary heart disease patients, and there were issues with this study, including the intervention basically just reminded people to take their medication, and the outcome measure wasn't great, but it suggests that there's a lot of promise to this kind of approach, and obviously that's the approach which we're going to be taking. Given that we're trying to do, we've got a big problem, we need to think about how to have a big solution to a big problem. And the REAIM framework is a public health framework, for thinking about how one can achieve optimal public health benefit from an intervention. So I think it would be fair to say that a lot of the time when people think about behaviour change interventions, they get very focused on the effectiveness or the efficacy. So they get very focused on how can we bring about a slightly bigger change in behaviour than previous interventions. Obviously, the changing behaviour element is important, but focusing just on that is kind of missing the big picture. And I would say that the big picture includes particularly trying to have an intervention which has a big reach, because even if one has only small effects on 850,000 people, those effects are going to be really, really worth having. And this is what the RE-AIM framework points us towards. The other things it points us towards are the idea of adoption by healthcare professionals, implementation of the intervention, and also maintenance, both within the individual changing their behaviour and also maintenance within the healthcare system. And again, I think maintenance is something that's been neglected to date, that one not only needs to have interventions which help people to change their behaviour, but that change needs to be maintained over the long term, over a period of years. And the intervention needs to be maintained within the healthcare system over a period of years. There's no good having an intervention which kind of is a flash and then it's gone. If you're going to have a big impact on these big problems, you need to have all these things. So I'm going to be returning to these ideas as I go through the talk this morning. Our intervention is intended to have very big reach. The novel idea behind this intervention is that basically we're going to link the prescribing databases where information about whether patients are taking up their prescriptions, we're going to link that to text messages. So what essentially is going to happen is if a person is prescribed a medication and then they don't pick up their repeat prescription, that is going to trigger them being sent loads of text messages. And again, the informatics people assure us that this can be done. Obviously, one of the things we're going to be doing in this trial is making sure that it can be done. But all the appropriate regulatory people are on board with this in the UK. So we think that we can do this. We think that it will be possible. People not taking up their repeat prescriptions will be sent text messages. So that all sounds promising. So that should have reach. It should be a thing which had fairly low unit cost. But then the next question which arises, obviously, is what on earth should one put into these text messages? And being a health psychologist who's interested in health behaviour change, that's the bit which I'm particularly interested in. So I imagine you're going to hear a fair bit from various people today about theory. I think theory is very important. Basically, if one has an intervention and it works, but you don't know how it works, then it's very difficult to optimise that intervention to make it work better. Similarly, if one has an intervention and it doesn't work and you don't know why it didn't work, you don't know whether you failed to change the thing you were trying to change, like get people to set goals or make plans or whatever. Did it not work because they didn't set goals or make plans, or did it not work because they made the plans and set the goals and then that didn't translate into behaviour? And the implications of those things are different. So if the intervention was successful in getting people to make goals and set plans, but it didn't translate into behaviour, that suggests that's not a promising approach for behaviour change. By contrast, if it didn't get people to make plans and set goals, for example, then that suggests that the intervention itself is not affecting the things that you want it to affect. So theory is important, and so what we're going to be doing in this study is trying to not only get an intervention which changes people's medication adherence, but also we're trying to understand why it changes medication adherence, or if it doesn't change medication adherence, we're trying to understand what did the intervention affect, and then why did that not translate into changes in behaviour. Okay, so sadly the NIHR didn't just write us a blank check when we walked in. We did quite a lot of preparatory work to set up the idea that this was a useful approach to take and building on existing research about what we already know. So this work was done in Manchester. So there's Andrew Farmer again, and then on the right, that is Jenny McSharry, who used to work in Manchester and now works in Galway. And she did the majority of the work on this review that I'm going to talk about. So essentially we did a systematic review to identify all the studies that have been published anywhere in the world which looked at the effectiveness of interventions to using monitoring or messaging of whatever sort with people with type 2 diabetes to try and then looked at the effects on medication adherence or effects on HbA1c, so that's long-term blood sugar levels. Amongst other things we did in the review was try to assess whether the interventions worked. We tried to look at whether the trials had risk of bias, and then we tried to look at the use of theory, what was in the interventions, and then how the interventions said useful things about what would be promising to try. We were hoping that we could get a good understanding of the sorts of things which have been shown to be promising in these interventions up till now. As you'll see, that it didn't quite work out. So we identified 11 published controlled trials that reported on 15 interventions. You can see for yourselves, some of them just included brief messaging, some of them just included monitoring, and some of them included a bit of both. And then maybe a half or two-thirds actually affected medication adherence. More interesting, so this is a forest plot. The further to the right the dots are, the more effective the intervention was. The ones on the left of the line actually had an adverse effect on medication adherence. People took their medication less as directed after the intervention than before. So I think that the main thing to sort of flag up from this slide is that there's quite a lot of heterogeneity in the studies. Some seem to work quite well, some seem to be actively harmful, and some seem to not work at all, which would fit with the wider literature on medication adherence. So one of the things we're interested in looking at is, can you relate effectiveness to what theories people used? The other thing I should say is that we also looked at the risk of bias of the study. The study quality of these trials was not great. In particular, the participants weren't blinded to the intervention, which is not surprising because it's quite difficult to blind people if you're sending them text messages. They're aware they're getting text messages. But more problematically, the people who were doing the assessment of medication adherence, whether the patients were taking their medication, they weren't blinded. So there's risk of bias in these studies. Coming back to theory, the big finding from this review was that only 4 out of the 11 interventions actually gave any reason at all why they thought the intervention should work, which is a bit of a hopeless state of affairs. That the interventions were described, they said we sent some text messages to people, and then they either changed or they didn't change their behaviour. They didn't give, or 7 out of the 11 studies didn't give any indication why they thought this should work, which obviously is a bit of a hopeless state of affairs, that text messaging is a sort of mechanism by which one can bring about behaviour change, but one needs to think much more about what is in the text messages to actually change the behaviour. Yes, and only one of these 11 studies actually measured the thing they were trying to change before the intervention and after the intervention, so to get some sort of idea about whether the intervention actually changed the mechanism by which it was intended to work. So this is a bit of a hopeless state of affairs. We can't really learn a great deal from these previous studies because we don't know what they were trying to change, we don't know whether they changed it, and most of them didn't even measure the thing they're trying to change. And obviously we're planning on doing better. This is a bit of a digression. Myself and the people in Oxford did a similar review in a related area, which was looking at interventions to change diet and physical activity in people with type 2 diabetes. Similar findings in that review. Only 3 of the 15 interventions we found in that systematic review were based on any theoretical principles at all. Bizarrely, only 4 out of the 15 studies actually even assessed whether they changed behaviour. They just sent the text messages out, and then they looked at effects on, I think it was weight and HbA1c, so blood sugar levels. So we're not even sure, the ones which worked, we're not even sure whether it worked because it changed diet or it changed physical activity. So again, a real black box problem there. We don't really know why these interventions worked. And in this case, the interventions did seem to work quite well. A consistent effect on blood sugar levels from these text messaging interventions, but we don't know why. Okay, So going back to medication adherence again, this was a systematic review of qualitative studies, which was led by Jenny McSharry. So we're looking at what are type 2 diabetes patients' experiences of taking medication. There's been the world of meta-synthesis of combining these qualitative studies to look at the big picture was one of the big studies in this area was done in the area of medication adherence. So we were focusing particularly on what is unique about the type 2 diabetes experience which affects people's medication adherence. So we found 8 studies, and then after various bits of analysis we came up with 3 higher order themes which describes the patient's experiences of taking these medications or not taking these medications. So here are the 3 themes. So people were quite happy with the idea that the medicines were beneficial, but they had negative perceptions of the medications. They didn't like taking them particularly. There were issues to do with identity, that once one starts taking medication, a person with type 2 diabetes starts taking medication, it confirms to them that they are a proper patient because they're not just managing it with behaviour, they're taking drugs for it. So it seems to be people are ambivalent about medications, which fits with the wider literature on medication adherence. People were quite happy to be prescribed medication, were quite happy to take the medication, but they were a common thing across all these studies was that the patients adjusted their doses. So people did things like they thought, I fancy having more jam on my toast today, so I have jam on my toast, but then I'll take extra medication to make up for the having the additional sugar. Or by contrast, there were a couple of studies, I think, that were done with Muslim patients in particular, and when they were fasting through Ramadan, they adjusted their medication. They just kind of tried things, see whether that worked, which is an interesting idea. It seemed, though, that a lot of the understandings that the patients had about what they were trying to do would not fit with the sort of medical thinking on this topic, though. So it may be that people are trying these experiments to see how it affects them, but given that a lot of the issues to do with type 2 diabetes, such as blood sugar levels, within a sort of range, they're not particularly symptomatic. So it may be that people are trying these various experiments, but they're not really getting the information from it that maybe they think they are. And then the third thing which came out of these qualitative studies is the stuff which is unique to type 2 diabetes, particularly around the idea that type 2 diabetes is asymptomatic, but people have these ideas about diet, physical activity and medication adherence which impacts on their adherence behaviours. So we're going to use these ideas in developing the contents of the text messaging, and I'll say a bit more about that in a moment. Okay, so there's lots of things one could do to promote medication adherence with text messages. Basically, one can do things to try and remind people, to try and get them to make plans so that they don't forget to take them, or one can do things which are a bit more persuasive to try and persuade people that taking their medication is a good idea. And one idea which it may be particularly important to convey to people may be that it's not just important to take the medication, but it's important to take the medication as prescribed, because that's where the people are going to get the benefits from it. Okay, so there's lots of things one could do. So what did we decide what are we going to do? What are we going to put into these text messages? So, given that it's difficult to learn an awful lot from the literature that's been done in this area to date, we're going to start off by mapping out things which look promising. We're going to cast our net quite broadly and try and identify things which look promising, and then we're going to sort of, through a process of refining the intervention, sort of narrow down the sorts of things we're going to focus the text messages on. So there's been reviews of the predictors of medication adherence. So there's been a big European review in Bangor that was recently done, which identified the constructs which are associated with people's medication adherence. So that's going to be one place we're going to start. We're going to look at successful interventions across behaviour, across any clinical condition, Successful interventions across other behaviours, so for example, getting people to make plans, set goals, self-monitor, that seems to be quite successful at changing behaviours like physical activity. So we're going to try and learn from those sort of interventions from other behaviours, given that the interventions for medication adherence don't seem to be working terribly well. We're also going to have a focus on theories of maintenance. So I think I said before that one of the issues with behaviour change interventions is that people focus, that we've got a pretty good idea now about the sorts of things which are likely to bring about changes in initiation of behaviour change, but our understanding of what are the things which lead to people maintaining those changes in the longer term is, I think, still quite rudimentary. We've got theories, they've been used somewhat, they've not been used anywhere near as much as they should be. And it may be that there's factors which are important in maintenance which are different from factors which are important in initiation. So, for example, it may be that emotional stuff is particularly important in terms of long-term maintenance. It may be things such as people being satisfied with the outcomes of their behaviour may be more important for maintenance than maybe for initiation of behaviour. So given that we want people to take these medications over a longer period of time, these are the kinds of things we're going to try and address with the intervention. Okay, so the intervention has to be acceptable to the people receiving the messages. They're going to be, on average, they're going to be older people. So if we start sending them text messages full of psychobabbly stuff about trying to increase their confidence and they don't like the messages, they may well opt out of the intervention at a fairly early stage. So we need to make sure that the text messages that we send to people are acceptable to them. We've done some PPI already, we've got further PPI planned, we're going to do focus groups of people with type 2 diabetes. Basically, we're going to present to them the ideas about the sorts of things which we think are likely to work, and then get their feedback on that. And then we're going to get their ideas about the sorts of things which would be likely to lead to acceptable or unacceptable interventions. So based on current empirical knowledge, based on theory, we've got a fairly good idea about the sorts of things which are likely to work, but we've got to make sure that the intervention is acceptable to people. So all the way through the development process, we're going to be doing qualitative work, we're going to be doing PPI with the patients to make sure that the intervention is acceptable to people. Because if it's not acceptable to people, it's just not going to work. Okay, so the sort of the first where the research really starts is actually developing the text messages. So starting with this sort of big scoping, casting the net wide review of the sorts of constructs which are likely to be useful at getting people to increase their medication adherence. We're going to basically develop text messages which which use behaviour change techniques to address those constructs. So for example, something which has been quite successful in changing behaviour generally is the idea of implementation intentions, where one tries to get people to make very specific plans about when, where, possibly with whom, one is actually going to take the medication. And so we're going to try and get text messages which exemplify that idea in 160 characters, and we're going to try and see how many, so that would be one example of the sort of behaviour change technique we're going to try and get into these text messages. We're going to try and generate lots of examples of these behaviour change techniques within these text messages. What we're going to do is we're going to get 15 experts in health psychology theory and diabetes clinicians to a one-day workshop in Manchester. We're going to try and basically generate lots of examples of text messages which exemplify the ideas by which we want them to work. So we're probably going to try and generate about 500 messages. We're going to maybe end up with about 20 different constructs, and we're going to try and develop about 25 messages to try and change those constructs. Again, the idea being that we're trying to have an explicit reason for why we think these interventions should work. And if anybody is interested in taking part in that, we'll be paying people €300 to see the lovely city of Manchester, to come over for the day and basically we work like dogs generating text messages. So if anyone's interested in doing that, then please talk to me, because we're looking for people who will be willing to do that. Okay, so having got the theoretical principles behind which we think the interventions might work, we will then go about refining the messages. We'll do a Delphi survey to make sure that the messages which we've generated actually map onto the constructs that we think they will do, and then we'll try and make sure that that maps onto theory to generate a logic model about how we think the intervention is going to work. We're also going to do an online survey with 30 patients to rate how acceptable they think the interventions are, again to make sure it's acceptable. I'm going to have to whiz through the sort of remaining slides. Amongst the issues we're going to try and address is we're going to do qualitative work with general practitioners to make sure that all they really have to do is enrol the patients onto when they prescribe a medication for the patients, they need to enrol them so that when they don't pick up the medication prescriptions, they will then start taking medications. But we need to make sure that how we do that is acceptable to the GPs, so we're going to do a lot of qualitative work to make sure it is acceptable to them. We're then going to go through a series of trials in line with the MRC framework for developing and evaluating complex interventions. We're going to do a feasibility trial, pilot trial, and a full effectiveness and cost-effectiveness trial. The feasibility trial is basically trying out the kit to make sure that it works and make sure that people don't hate any of the messages. If they do hate some of the messages, we'll get rid of those messages. And basically get them to reflect on how they found the intervention to try and optimise the intervention. So we'll develop the intervention and then we'll try and optimise it. We will then do a pilot RCT which will have feasibility elements as well. So I think there will be 12 GPs that will help us with recruiting patients. We're going to recruit 200 patients. We're going to try and get a handle in that on mechanism. We're going to try and, by getting the patients to complete the measures of process as well as receive the intervention, to try and get some sort of sense about whether things are working well, things not working well. We're going to try and work out which messages people don't like. They'll be able to respond when they get the messages. If they don't like the messages, they'll be able to respond saying, I don't like this message, and then we'll not send them any more messages of that sort. Okay, so there's a lot of developmental work. I think the key thing though, or one of the key things about this intervention is we are keeping our eyes very much on implementation. When we've been through loads of rounds of feedback from reviewers and from the NIHR panel, they kept saying, well, this is fine, it's a SMS intervention, why don't you do something a bit more fancy, why don't you have an app, why don't you, and basically trying to sort of make the intervention more effective. We will have a study website which will give information about medications and the study itself, but we've been trying to keep the intervention simple so that if it is effective, it could be implemented routinely. One of the issues with more complicated eHealth, mHealth interventions is keeping them updated, and the more complicated an intervention, the more difficult it is to implement. So we're trying to keep something as simple as possible that could be implemented and could have big reach. And to make sure, or try and optimise the chances of getting it implemented, we are ensuring that key stakeholders are engaged from early on, and we're doing qualitative work to make sure it's acceptable all the way through. I think I've said all that. So thank you very much.